there any questions on the previous week's material? Everyone did okay with the homework assignment? Hopefully. Right, the goal is not to be, the goal is to be as accurate as you possibly can, but obviously you guys are not already practicing clinicians, so there's going to be some things you may not understand, or you may not be super aware of some of the kind of intricacies of things. There's our stragglers. I said we all coming together, that way we don't get noticed as much, right? But the goal is to at least start to get you to start thinking, at least clinically, to start thinking about drugs and their use and whatnot. So I'll go through those and see how they look and maybe provide any feedback if I notice anything that could use a little bit of tweaking. So anywho, continue on. Today we talked a little bit about receptors previously, and now we're going to move into looking at secondary messenger systems and how those are going to play a role in mediating some of the physiologic effects that you guys were probably seeing with these medications. So we'll look at some of the more common ones we're going to run into. We'll identify some of the drugs that actually interfere with this the second messenger system and see how that clinically comes up. And then we're going to look at dose-response relationships. So we're going to look at things like talking about ED50 and LD50 and all of that and what those mean for the drugs that we're talking about. So first off, second messengers. Right, so these are going to be the molecules that are going to relay signals from the receptor on the cell surface most often. We said that sometimes the receptors would actually be intracellular, but most often they're on the surface. They're going to relay a message to target molecules within the cell. The most common ones we're going to deal with are including cyclic AMP. So it's going to be cyclic adenosine monophosphate. There's going to be kind of a close cousin to that, going to be cyclic GMP, which is cyclic guanosine monophosphate. And then we're going to talk about calcium as being a very important cell signaler, and then this phosphoinositide and how that plays a role with calcium. We're going to see that these can be activated by several different things. In some cases, they will be activated by enzymes. In other cases, they may be even opening of ion channels, right? So by changing the voltage of a resting membrane, by either making it hyperpolarized or by depolarizing, you may have activation of some of these secondary messengers that will allow for these kind of downstream signals to occur and allow for changes in blood pressure or change in blood sugar, or whatever it happens to be. Okay. So the first one we'll talk about is cyclic AMP. This is one of the more common ones you're going to run into. And basically this gets generated from ATP. You guys familiar with ATP? What does ATP do for us? Yeah, it's all energy, right? So it has high energy phosphate bonds, and so we use that a lot for the active processes within the cell. ATP can then be acted on by this enzyme called adenylyl cyclase, and that will convert it over into cyclic AMP. And basically, cyclic AMP can then go on and target these molecules called kinases. And we saw some tyrosine kinases in the last lecture, but basically that just means that they phosphorylate something. So cyclic AMP is going to go along and activate these protein kinases, and then you can have downstream physiologic effects that occur from there. In some cases, you may be changing gene transcription so that you have increased protein production. You have lots of different things that occur here. So some examples of this would be things like glucagon. You guys familiar with that hormone? What does that do? It's the opposite of insulin, so it does what to blood sugar? Yep, should raise it up, absolutely. So we have things like ACTH or adrenocorticotropic hormone, which is very important for things like cortisol expression, thyroid stimulating hormone, vasopressin, otherwise known as antidiuretic hormone. They all work through cyclic AMP. Okay. So basically what you can see here, and you guys remember those G proteins we talked about last time? Hopefully you haven't blocked out those memories already. Basically, you have some sort of messenger molecule that's going to come along here and bind to a G protein, right? So we said they're going to have these kind of, basically you can end up having G proteins here. You can have several different types of receptors here, but essentially what happens is you're going to eventually have these G proteins get activated. GTP is going to be, noticing here, when it's GTP, it's going to be in the active state, but basically that can go along, that alpha subunit can go and activate adenylyl cyclase. That will catalyze that conversion from ATP over to cyclic AMP. Then you're going to have activation of these protein kinases will go over to the active form, and they can go down to, say, the nucleus and change gene transcription, or it'll activate things like glycogen breakdown, so you can raise your blood sugar in the case of glucagon, so whatever the downstream thing is. But the important thing here is that adenylyl cyclase and cyclic AMP are going to be the secondary messengers. They're going to be the middlemen. And what's important about this is that you can have one receptor being activated, which can activate the G protein, right? That G protein is not only activating one molecule of adenylyl cyclase, it can go and activate several adenylyl cyclases as long as it's still active, which can lead to this kind of cascading type of effect where you can have a very small signal, maybe only one receptor being hit, and you can have several of these adenylyl cyclases being activated, lots of CAMP being activated at the same time. You can have this kind of cascading type of effect. Okay, so very small amounts of drug are able to cause very big effects in the body essentially. Just another picture of how this can work. Again, you have the G protein being activated here. This will go on, once it's activated, go into effect adenyl cyclase. You have this activated, these protein kinases get activated, and then you're going to have these go down. And you can notice how in this case it would actually change gene transcription, increase protein production, whatever happens to be, that would be the downstream effect that would be occurring there. I'll show you some more examples of how this is really important for us. So as an example, we're talking about glucagon more specifically because most of you guys are already familiar with it. But basically, it helps to mediate a lot of hormonal responses. In the case of glucagon, that helps to break down glycogen in the liver, which is kind of our storage spot for a lot of glucose that gets released out into the bloodstream. Then we can use that for energy, essentially. You can also see in the case of the kidneys, you can have vasopressin, otherwise known as antidiuretic hormone, will help to conserve more water within the kidneys by increasing the amount of aquaporins that you get put into the renal tubule. I'll show you some pictures in a minute. We'll see calcium homeostasis is really mediated through parathyroid hormone, and so this can help to lead to have further calcium deposition or liberation of calcium from the bone in order to regulate our calcium levels in the bloodstream. And then another big one we'll see cyclic AMP being used is with increasing things like heart rate and the force of contraction via catecholamines. And when I reference catecholamines, I'm mainly talking about like epinephrine, norepinephrine, things that are being released by the sympathetic nervous system, or like epi coming from the adrenal gland. That's really going to be those catecholamines we're talking about there. Okay. So looking at this picture, this is a little bit more detailed than what we need, but I'll show you kind of the essential pieces here. So if you note, we have something like epinephrine. They can go in and activate this G protein. You're going to see the activation here. Adenyl cyclase is going to convert ATP over to cyclic AMP. This will activate these protein kinases. And again, if you think about your fight or flight response, right, because the sympathetic nervous system is where epinephrine gets released, right? Fight or flight response, you're running away from, say, a bear or something. What does your blood sugar need to do? But yeah, it needs to increase. You need energy, right, to run away, to keep your muscles in energy. So one of the things you can see with the sympathetic nervous system is epinephrine is going to stimulate release of glucose into the bloodstream through similar actions to what you might see with glucagon. So what you're going to have here is that epinephrine is the activator. It's going to eventually cause these protein kinases to be activated, and this is going to lead to breakdown of glycogen. Eventually, this glycogen gets broken down into free glucose, and this gets sent out into the bloodstream. It can then circulate around, be taken up by the tissues wherever energy is needed, and be utilized to produce new ATP. Okay. Another example, we mentioned arginine vasopressin, or antidiuretic hormone, being utilized here. We can see cyclic AMP being activated, and this will lead to insertion of things like sodium-potassium pumps. It will allow for these aquaporins to get put into the channels, so that way you can reabsorb more water from the kidneys. Because you guys think about antidiuretic hormone, you guys know what the main response, or when your body is sending out antidiuretic hormone? Keeps you from losing water. So it's usually when your blood is getting too concentrated, right? So if your osmolarity of the blood is getting too high, the brain's going to respond by sending out antidiuretic hormone because it wants to hold on to more water to try to dilute out the salt in your blood, essentially. Okay, so antidiuretic hormone will work to put these aquaporin channels in there, so you absorb a lot of water, and that way you can end up having dilution of the blood, and things get back down to a normal osmolarity, essentially. Okay. And then here in the heart, we can see where you can have a sympathetic nerve terminal, and I mentioned this will release things like norepi onto the heart. This would be a beta adrenergic receptor. Have you guys covered anything about the heart yet and heart function? Right, so you know that beta-1 activation specifically causes increased chronotropy, so the heart's going to beat faster. It can also increase contractility of the heart to positive ionotropes, so it's going to be stronger, right? So basically by activating that, you're going to have adenyl cyclase getting activated. That's going to lead for actually more calcium to come in. Right, so this PKA, this protein kinase, actually leads to calcium being entering into the cell. And if you look at the cardiac physiology, you'll know that calcium coming in, more calcium in means you're going to have more calcium being released from the sarcoplasmic reticulum. That means you have a stronger contraction of the heart. Okay, so that's why with epi, you get that sympathetic activation. Like if I get really nervous about something, like I can have a lot of epi hitting the heart, it's going to cause increased calcium. The heart's going to beat faster and stronger. And I'm going to be able to run away or do whatever I need to do. Okay. So it's actually kind of interesting because in some cases, like from a tox standpoint, we might use very odd kind of drugs that don't really make a ton of sense for what we're using them for. So for instance, if I were to have a drug that blocked these beta receptors, so like a beta blocker, right? I'm sure some of you might have had a beta blocker as your drug assignment. But basically, if you were to cover up this beta receptor, right, with an antagonist that would block it, you'd end up getting, or can you think of the physiologic effects you would see from that? So your heart rate go up or down? probably go down. You see your blood pressure start to drop. And so when patients overdose on a beta blocker, they get very bradycardic, they get very hypotensive. And so one of the things we need to do is to try to get their heart rate back up so their blood pressure will come back up as well. And so one of the things we can actually do is instead, because these receptors are being blocked up by a drug, we can actually go through some backdoor channels. We can use other drugs that may be able to activate similar processes in order to get the heart to beat again. So what we can actually use is do glucagon. Glucagon is something you wouldn't necessarily think of as an antidote, but we can actually give it here. It will activate these similar adenylyl cyclase receptors, or these enzymes, and that will lead for more calcium to come into the heart and allow for the heart to beat stronger, faster, and bring up the patient's blood pressure. So again, just an example of like some odd ways we can use drugs in order to kind of counteract the effects that we're seeing due to other medications. Okay, so the cousin to cyclic AMP is going to be cyclic GMP, or guanylyl cyclase will be the enzyme here that converts GTP over to cyclic GMP. You're going to find it is going to be really responsible for causing a lot of regulation in smooth muscle contraction. You're going to see it works in the intestinal mucosa. It actually can help to regulate ion channel conductance, so how the ions are going to flow into and out of the GI tract can be affected here. Works a lot in the vascular smooth muscle, so this will be really, really important for helping to relax vascular smooth muscle and allowing for hypotension or to try to drop blood pressure. I'll show you a really good example of that in a second. Basically, by opening up the blood vessels, you get better blood flow. And so if you're in a case where, I guess what's a medical emergency where you may have impaired blood flow to a certain important organ? Yeah, like myocardial infarction. Like, so if you're having angina or that kind of chest pain that's associated with having not enough oxygen getting to the heart, we can give you a drug that can actually work through cyclic GMP to open up those vessels and allow more oxygen or oxygen-rich blood in order to hit the heart. Do you guys know what that drug might be? Any EMTs would know. It's the first thing you give when someone complains of chest pain. Nitroglycerin, yeah. So nitroglycerin actually works through this pathway here, and I'll show you that. But looking at, say this is a smooth muscle cell right here, again, you can have your agonist affecting the guanylyl cyclase. That's going to convert that GTP over to cyclic GMP. And in some cases, we'll actually do things like open up this channel here, where we can actually have things like calcium flowing out of the cell to make it more difficult for that muscle to contract. When we go, if you guys cover like muscle physiology in your course, other courses, you should see that calcium is really, really important for actin and myosin to come together and cause a muscular contraction. But by doing these sort of things, by getting rid of calcium, it's able to cause smooth muscle relaxation. Thus, you're going to allow for blood vessels to get bigger, allow for more blood flow, better oxygen delivery. Okay, you guys ever heard of the drug sildenafil? It's used for erectile dysfunction. It's also known as Viagra. Okay, so this is actually kind of interesting because Viagra works by inhibiting this enzyme called PDE5 or phosphodiesterase, and this is a really important enzyme because it actually breaks down cyclic GMP back into just regular GMP. Because again, if you have too much cyclic GMP around and you are causing the smooth muscle relaxation, what could be a possible side effect of that? You have too much relaxation, you can get hypotension, right? So you get too much relaxation, have hypotension that can develop from this. So this is why phosphodiesterase will come along, it will metabolize that cyclic GMP, and then you have a better regulation of that. So one of the big side effects they always tell you is that if you are taking one of these medications for erectile dysfunction, don't take nitroglycerin with it. Because we're going to see that nitroglycerin will stimulate this process, and so now I have a lot of cyclic GMP from that drug, but now I'm inhibiting the breakdown with this other drug, and so you can get really, really profound hypotension. So people have died from that before because they've mixed these two drugs together. Okay, so you're going to start to see where these kind of biochemical reactions can interact with one another to lead to some pretty significant side effects. Okay, we'll talk about those later when we get to actual pharm and go through those specific examples. Again, nitric oxide is going to be a really important kind of pathway here. We'll look at things like prostaglandins and prostacyclins here in a little bit, but basically the main thing I want to focus on is this guanylate cyclase converting over to eventually get cyclic GMP. That's going to lead you to get vasodilation. That's really the big thing we're going to be focusing on there. And if you had someone who is having chest pain or myocardial ischemia, manifesting itself as angina, nitroglycerin is going to be one of the first drugs we give to them. Basically, nitroglycerin gets converted over to this molecule called nitric oxide, and that actually activates guanylate cyclase. You're going to have more cyclic GMP that gets activated. You're going to lead those protein kinases leading to smooth muscle relaxation, and now those coronary vessels are wider. They're going to be more open. They're going to allow for more oxygen-rich blood to hit the heart, and thus you're going to have relief of that chest pain. That's the goal, at least. If not, you probably need to get to the ER because you're probably dying. So, that makes sense so far? Second messenger we'll talk about in detail is going to be calcium ions and this inositol triphosphate pathway. Calcium is more widely used within the body as a signaling molecule than even cyclic AMP is. It's very important for things like neurotransmitters, for growth factors, some hormones are involved here. We'll see that calcium influx into a cell can lead to things like muscle contractions, can lead to more secretion of certain substances, can even have important aspects or important effect on cell division, right? So it can trigger things like mitosis to occur and whatnot. We'll see there's also this other molecule called IP3, this inositol triphosphate, that will also function to mobilize calcium from storage to get some of these above effects. Because again, when you look inside of a cell, you're going to notice that a lot of the calcium is not free. Most of it is going to be contained within a certain part of the cell. Do you guys know what that is? Usually in the muscle, it's called the sarcoplasmic reticulum. Otherwise, like in normal other cells, you might see the endoplasmic reticulum. That's usually going to be a storage depot for a lot of calcium. Okay. Basically, what you're doing, I'll show you a graph of this or a picture of this in a second to kind of make more sense. But phospholipase C is going to be one of the main enzymes here. It's going to be bound by the membrane, so it's going to be right there on the cell surface. Once it gets activated by something like a G protein, so for instance like GQ, mentioned there's lots of different subsets of G proteins. When it's active, it's actually going to lead to this breakdown of this phosphatidylinositol 4,5-bisphosphate. You guys don't have to be able to say that or write it down for a test, but just know that you're going to have two active signaling molecules. You get this IP3, or that inositol triphosphate, and another one called DAG, or diacylglycerol. Basically, IP3 is very water soluble, it's very small, it's going to be able to get out of that membrane. It's going to get into the cytosol of the cell where it can then bind with some of these receptors and allow for release of stored calcium. That stored calcium can then act as a signaling molecule where it can go and do whatever downstream effects it needs to. Meanwhile, you can see that DAG is going to stay within the membrane and will further activate protein kinase C to cause other potential physiologic effects. Here's a picture of this where you can have like a G protein being activated by a signaling molecule. This will then go and activate. You can notice the phosphatidylinositol 4,5-bisphosphate. Notice right here. That will cause the cleavage of that to where you have the diacylglycerol being able to activate its own protein kinases. You can also have that inositol triphosphate being released here to activate release of calcium outside of that endoplasmic reticulum. Pretty straightforward. You'll find that lots of drugs work through some of these different pathways. Again, clinically, no patient's going to ask you, well, does this drug work through the IP3 pathway? No, but it could be important because you need to know kind of these background methods for how these drugs are working so you can understand drug interactions. You can understand why some drugs may work for some patients versus not other patients. And so some of this can come into play there. And we'll highlight those examples when we're actually talking about them in pharmacology. Okay. So again, you can have multiple signaling pathways that can all be affecting different things. Sometimes you can have antagonistic effects. Sometimes you can have synergistic effects. So for instance, look here, we have a vascular smooth muscle cell. So this is helping to regulate blood pressure by either contracting or dilating. And so you can see things where like epinephrine can bind to these beta-2 receptors. Can lead to cyclic AMP being upregulated and lead to relaxation there. Okay, it'll be really important when we get into cardiovascular pharmacology to remember which receptors are doing which action. Because you can find that in some cases, epinephrine may be activating alpha-1 receptors and can lead to vasoconstriction, leading to hypertension, right? So we'll kind of go over those differences when we get to them. We can have other things like angiotensin II. Have you guys ever heard of ACE inhibitors? Right, ACE inhibitors are going to be something that we use to prevent production of angiotensin II, which is a potent vasoconstrictor. So that's one of the main causes why people have hypertension, because people have a lot of angiotensin II around. So just know there's a lot of different pathways here. Some are going to lead to things like contraction, some will lead to relaxation, and you'll see how different drugs can be involved in these processes in order to lead to treating hypertension or to treat an MI or whatever it happens to be. Okay, so any questions on that? Pretty sure I just swallowed a bug while I was talking up here, so it's super gross, but I'm glad I kept talking. Okay, moving on, we're going to talk about dose-response relationship. So when we're looking at pharmacodynamic studies, we're going to find different doses of a drug can be tested, and they should be tested because you're going to find that depending on the group of patients you're dealing with, depending on the subset of the makeup of those patients, you're going to find different effects, right? Because everyone's a little different. Everyone responds to drugs a little bit differently. You can also do drug studies where you're looking at effects on specific tissues, cells, organs, whatever it happens to be. You can look at that as an isolated case, but in a lot of cases we're more worried about patients, how they actually respond to the drugs. We're going to see and talk about today are going to be these dose-response relationships, and basically this is a relationship between drug concentration at the receptor and the magnitude of that response. So if I give you 10 milligrams of this drug, it's going to cause this big of a drop in your blood pressure. If I give you 10 milligrams of this drug, you see a different drop in your blood pressure, right? So how that response how the patient responds to that drug at a given dose. So So again, there should be a relationship between the amount of drug and some sort of effect I'm going to get out of that. So again, lowering blood pressure, changing your blood sugar, causing you to release more cortisol, whatever it happens to be. And this dose response data is really important because these mathematical relationships can signify to us, how the drug is going to be working according to a specific second interaction between different molecules in the body. This can help to inform us of how different drugs maybe interact with one another versus endogenous ligands, all things like that. So these are the sort of studies that are done on the back end before the drug is ever sent out to market. But it's important to understand these relationships now. So you say, like, okay, well, why do we dose this drug at 100 milligrams, but this drug only gets 50 milligrams, and they do the same thing? This is going to be a lot of those relationships we're going to talk about here. Okay. All right, so some of the things that we should show when we're testing drugs for their efficacy or their effects, you basically need to show 3 things. One, if the drug is not there, you shouldn't get any effect. It's pretty straightforward. Say for instance we're testing an antihypertensive or drug to lower blood pressure. If I don't give you any drug, blood pressure should stay at baseline. Makes sense. If I add more drug up to a certain point, you're going to see that every drug kind of has a plateau effect where you kind of limit the amount of actual efficacy you get out of it. You're going to cause an incremental change in effect, so that if I give you 10 milligrams, I should see this drop in blood pressure. If I give you 20 milligrams, I should see a bigger drop in blood pressure. Okay, and then if I take that drug away, there should be a return back to the original effect. Okay, so your blood pressure should go back to the original baseline level when I take that drug away from you. Okay. This is getting you prep for all the drug experiments we're going to be doing in here. This is the only way I can get able-bodied volunteers, so it will be a factor on your grade. So, anywho, when you're looking at these dose response curves, this relationship to dose to the response is going to be illustrated on these kind of curves here. So you notice the response is going to be in the y-axis here, log of the dose, and we'll talk about why that's going to be the log here on the x-axis. And you'll notice here that as I have no drug around, you should have no effect going on. And as I gently increase the dose, you're going to start to notice an increase in response. And what do you think is happening here once I get this kind of plateau? Basically, I've saturated all of my receptors. Basically, I have no more receptors to hit. The drug is bound to every single receptor, and you get kind of a maximal effect you can ever get out of that drug. And that'll be important when you're comparing different drugs together to see how the efficacy is going to stack up between one another. So again, I mentioned the plot. The x-axis is going to be the concentration of the drug. Y-axis, you can change kind of whatever effect you're looking for. So if you want to look at enzyme activity, if you want to look at accumulation, say, of a second messenger, membrane potential, secretion of a hormone, really y-axis can be anything you want as long as you're being consistent in how you're kind of comparing different drugs together or whatever you're doing. So one of the first terms we'll see is going to be the ED50, or this is the median effective dose. This is essentially the dose at which you're going to get 50% of the population or the sample manifest that given effect, right? So it's going to say when I start to give this drug, whatever the halfway mark is between the minimal effect and the maximal effect, that should be my ED50, okay? This is a very useful comparison point where now we can compare different molecules together by looking at their ED50s, okay? Make sense so far? We're going to find that you can talk about either the degree in drop. So say, for instance, if this is like, say, no change in blood pressure, this is 10 millimeters of mercury, this is 20, 30, 40. You can do it that way, or you can say, like, this is the percentage of people who are manifesting whatever outcome I'm looking for. So I can say if I'm doing like a sleep agent, what are the percentage of people who have actually gone to sleep, right? So I can say, okay, here's 0 people gone to sleep, here's 10%, 20, 30, 40, 50%, and et cetera. So we'll kind of look at how those curves will change a little bit based on what we're looking at. This is, I'm sorry. So ED50 is really good for comparison between different molecules, right? So I can look to see, like, because again, when you give a drug to a patient, do you want like a 50-50 chance that they're going to have the effect you want? Yeah, you want better than that. You'd like to hope close to 100% that if I give you this drug, you're going to have the intended effect, and that's good. So typically you're dosing much higher than your ED50, or depending on the drug, you may not have to dose very much higher, but we'll look at that in a second. But I can compare different drugs together, and we'll look at that in just a moment. So that'll be more clear in just a second. It's really good for comparisons, yeah. That in a second. When you're looking at how it's plotted, so you can do it as a linear graph, and you can look to see here how this would be kind of a linear relationship along this one is actually looking at receptor occupancy, so you have 25, 50, 75%. More commonly what we do is a semi-logarithmic graph. This is more useful for comparing drugs across many tenfolds of concentration, right? So this is an example down here where we could look at between 0.1 say milligrams, you're giving all the way up to say 30 milligrams, and you can go even farther than that. And this is useful because we mentioned that different drugs have different potencies. So for instance, that drug I mentioned for surgery, used for pain relief, fentanyl, is dosed in micrograms versus something like morphine is dosed in milligrams. It's a 1,000-fold difference there in dose, and I want to be able to compare the two together to see what their efficacy is, to see what their comparative affinity or their potency is going to be between the two. And so these curves will allow us to do that, and that's why I use the log of the dose there. So again, this helps us to make it a little bit easier to estimate that ED50, and we'll see some more examples here in just a minute. But you notice here I can plot multiple drugs on the same chart, and now I can start to make some comparisons between the two, right? So notice the ED50 would be here for drug A, here's the ED50 for drug B, and then you notice how the ED50 is lower here for drug C, and we can start to make some inferences about the efficacy and also the potency of these drugs based on these comparisons. All right, so for kind of standard parameters, you're going to have your baseline response, which should be the bottom of the curve here. You're going to have a maximum response. It should be indicating when you've kind of had full receptor occupancy, when you're getting as much effect out of that drug as you possibly can. We'll talk about the slope here. So you can have drugs that will have a very narrow, or have a very shallow slope, or drugs that have a very steep slope. So what do you think the difference is between those two? It's very steep. What do you think that would mean? Yeah. So basically, small changes in dose are going to lead to big changes in effect. Okay, if it's a very, very steep curve. So like for this one, if it was almost sitting straight up, you see very, very big changes in the effect you're getting, or the number of people that are getting that effect, with small changes in dose. Okay, versus something that has a more shallow slope. If it'll say something going, I guess I can use a pen. Let me see. My handwriting is very, very bad. So, and plus I'm left-handed, so just bear with me. Oh, that's white. Why was that white? Let's say we're looking at another curve. We can say very, very poor drop. Okay, so anyway, so if you're looking at this, it's much more shallow kind of a slope there. That means you can have a bigger change in dose in order to get the same type of change in effect versus another one that, say I had a drug that was kind of plummeted like this. So this would be a more kind of steep slope. That means big, big changes with small changes in dose, or big, big changes in effect. Yes, ma'am. That's a good question. We're going to get that in just a second. Glad you're thinking ahead, though. Those are good segues. All right, so anyway, so again, ED50 is going to be half that maximal effective concentration. It's going to be located halfway between the baseline and your maximal effect, and this is going to help us to determine potency, especially when we're comparing two things together. Okay. So again, we can look at dose-response relationships either being in this kind of graded response or arithmetic response. This is going to describe the effect at various doses of drug on an individual, right? So this would be if I was to give you varying doses of a drug and I say, okay, this dose drops your blood pressure 10 millimeters of mercury, this one does 20, 30, 40. That's going to be basically the effect on one individual person versus these quantal responses, which are going to be all or none. That's going to be better for if I'm looking at the number of people who had a 20% drop in their blood pressure or the number of people that achieved sleep. Like that's going to be better for those type of responses. And so depending on the drug or depending on the type of study you're doing, you may be looking at different responses there and use one versus the other. So again, looking at these graded dose response curves first, we're going to see that as the concentration of the drug increases, the magnitude of the effect should increase as well. Pretty straightforward. And that dose of the relationship between dose and response should be continuous. There shouldn't really be any big jumps between how the doses increase and how that patient should be responding to that. And basically, you can kind of mathematically describe this as a relationship between the drug and the receptor. When the drug and the receptor come together, that's when you're going to get your effect. If you have more of those drug receptor complexes coming together, a bigger effect essentially. Okay. And when you have all the receptors being bound up, maximum effect should be achieved there. Okay. So again, the response is going to be this graded effect, meaning that response is continuous and gradual, as we kind of saw already, versus when we're looking at the quantal response curve, that's going to be kind of an all or none phenomenon. I'll give you some examples of those in a minute. And so a graph of this relationship, we'll call this a graded dose response curve. So again, illustrating the relationship between drug dose, receptor occupancy, and that magnitude of that effect that's happening there. Okay, and so then for a given drug, when the maximum response is going to be produced when all the receptors are bound up. So again, no more drug, or you can keep adding drug as much as you want, but you're not going to get more receptor activity out of there because they're all bound up. And that half of that maximum response, or the efficacy there, should be when half of the receptors are being bound up. Okay. So when we're looking at this, you can see that how far along the x-axis here is going to be determining the potency of the drug. Okay, so farther along to the left, you should be seeing more you're going to need lower amounts of drug in order to get the same type of effect. Okay, we'll look at some comparisons in a minute, but just know that the farther to the right the curve is, the less potent the drug is. I mean, I need to give a higher dose in order to get whatever effect I'm looking for. Okay, you're going to see that the maximal effect here, as high as the curve goes, is going to be determining the efficacy of the drug. Okay, so if I have something that had a lower maximum effect, I know that drug would be less efficacious than one that had a higher curve. Okay. So again, potency is referring to that amount of drug. Usually it's in milligrams, but we saw some drugs are in micrograms, some drugs are in nanograms, some are in grams. Big wide ranges of dose there. But again, when you're looking at this, you can say, like, okay, what's the pain relief that I'm experiencing here? You know, you can do that on a graded scale. How much blood pressure lowering am I having occur there? But again, a drug's effects can be evaluated based on the strength, which again is that potency, so how much drug you need to get an effect, and the effectiveness, or the kind of maximal efficacy you get out of that. So if you were looking at, say, 3 different curves here, so you have drug A, B, and C, which one would you consider to be the most potent drug? Drug A, right? So you should be able to get the same type of efficacy, right? The same effect with less drug than drug B or drug C, right? So drug C would be the least potent out of this whole bunch. So I would need to give more drug to get the same type of effect. But notice how they all have the same efficacy, right? So as long as I'm adjusting my dose appropriately, and we said the efficacy is ultimately more important than potency because we can change the dose and adjust it so that you get the right effect you're looking for. I can give either 3 of these drugs, and I would say, okay, either of them could work for whatever I'm using it for. So lowering blood sugar, lowering blood pressure, whatever happens to be. Okay. Some of the things that may lead you to choose one or the other could be things like side effects, could be different changes in some of the kinetics on how the person may clear it or absorb a drug. Lots of different factors will go into this. So you can have lots of drugs that are equally efficacious, but you may lead to using one versus another for several different reasons. Okay. So again, all these would be equally efficacious, but drug A would be the most potent, drug B in the middle, and the drug C would be the least potent. So looking at this, you have 4 different drugs here, so A, B, C, and D. Out of this bunch, which one do you think would be the most potent? On the slide. So drug A would be the most potent, right? Would be farther along on the left. Drug D would be the probably least potent, right? And so we'll look at efficacy in just a minute, but again, by comparing these curves together, you can kind of see, okay, well, I would need much less of drug A to get a desired effect, to hit the ED50, than I would need for drug B, drug C, or drug D. Drug D would obviously need the most drug, which may be grams of a drug, versus micrograms of a drug for drug A, okay? Now, on the other hand, when looking at efficacy, we can see that the ability of the drug to produce an effect is going to be termed the efficacy. We're going to see that agonists are going to have that positive efficacy, right? They're going to cause something to occur when they bind to that receptor. And we look at antagonists, they're going to notice they have 0 efficacy because when they bind that, they're actually preventing other things from coming and activating it. Remember, they're talking about competitive antagonists, they'll just sit on the receptor and not actually activate it, right? So they shouldn't have really any effect. We'll talk a little bit later about inverse agonists, and I get the opposite effect, but for the majority of things, when we're talking about antagonists, they sit on the receptor and they don't do anything. Okay, so 0 efficacy at that point. So again, a drug with greater efficacy is going to be more therapeutically beneficial than one that is more potent. So when you're looking at your dose, your drug doses out there, and you say, well, why is this drug dosed in milligrams versus this one in micrograms? We don't really care about the potency so much. The thing we're looking for is going to be the efficacy that we can get out of that drug. So again, when it comes down to choosing between micrograms of fentanyl or milligrams of morphine, I don't really care. Either one can help to fix my patient's pain. I may choose fentanyl because the patient has a morphine allergy, or I may choose one versus the other because one's cheaper. Right? So there are other factors that come into play there. But as long as they're equally efficacious, I don't really care what dose I have to give. So over here, which one of these would have the highest efficacy? What do you think? So A, you think A? What about C? Yeah, A and C. So they're actually, A and C would be equally efficacious in this case. You would just need a bigger dose of A, or I'm sorry, smaller dose of A in order to equal the efficacy of drug C. Okay, so C would be less potent, but equally efficacious to A. Versus when we're looking at, say, drug B or drug D, those would be less efficacious than A and C. And again, their dose would just have to be adjusted based on potency. Make sense? And again, how often do you think you guys are going to look at this in the clinical world? Probably never, right? The thing is like, all this has been done on the background, so that when you look at your pharmacopoeia, or you're looking at your drug reference, like all this has already kind of been done. So you can see, like, okay, if I need to treat a UTI, urinary tract infection, I can use this many milligrams of this drug to treat it, or I can use this many milligrams of this drug to treat it. All that's already been taken care of. So you know that I can give either drug, and they're both going to treat my patient. Okay? Do you have a question?
So like D, that could be also over D, will B have more efficacy?
D and B would probably be about equal there. Okay. Yeah, but just note here that, for instance, if I were to give, say, different doses of drug B, there would be kind of a more gradual change in efficacy as I increase that dose, versus for drug D has a pretty steep dose response curve there. Yes, ma'am.
Yeah, how about the side effects?
We'll talk about those in a second. Yeah, absolutely. Another good segue. So again, looking at this associated with the vertical axis on the dose response curve, the higher the curve, the more effective the drug is. And again, unlike the potency, efficacy is relatively important for us because that's going to be the maximum attainable effect of that drug. Okay. We're usually not dosing a drug in order to hit every single receptor possible. Usually we're dosing less than that, but we're also dosing well above the ED50 to try to hit a sweet spot where we're going to be getting the most effect out of the most people. But we're also going to look at how that compares to side effects in just a minute when we look at some of these other curves. Okay. All right, so I mentioned already here, if you're looking at this curve again, in order of efficacy, you see that A and C are pretty much equal. In this case, B would be a little bit more efficacious than D. Okay, so we talk about affinity and this intrinsic activity. So we can see that one of these important factors that goes into potency or ED50 is that affinity of a drug for the receptor. That's basically how tightly it binds to it. If a drug can come along and bind very tightly and does not like to dissociate from that receptor, that means it's going to have a high affinity. If it binds very lightly and it can dissociate very easily, that's a relatively low affinity. Okay? This is important, especially when you have different drugs that are trying to fight for the same receptor. Things with high affinity tend to bind to it and like to stay there for longer, so the other drug, which may have a lower affinity, can't really get to it. Okay? So again, it's going to be the quantity of the drug that reaches the receptor, so it has to get to its site of action, and then the affinity there, that degree of attraction it has to the actual cell surface. And then when we're talking about intrinsic activity, we mentioned things can be a partial agonist or a full agonist. Remember that previously? Right? So that's kind of what's helping us to determine the different efficacies of different drugs, is how much intrinsic activity it has. Okay, so we can have things that we'll look at this measure of the drug's ability that once it's bound to the receptor to actually generate the effect that we're looking for. Some things will be full agonists, some things will be partial agonists, and that's why we have some of that different efficacy there based on how they interact with that receptor. Okay, agonists can have, they're both going to have affinity and intrinsic activity you have to consider, and they can be either full or partial agonists. But again, remember, antagonists are going to sit on that receptor and have no affinity, no activity whatsoever. So again, when we're looking at these quantal dose-response relationships, so these are going to be the all-or-none kind of phenomenons we're talking about. This shows kind of a population response. So if I do a study in, say, 29 PA students, and I see how many people are put to sleep by the end of this lecture, that could be, I could plot that as kind of a quantal dose-response curve, say, over time or something. I guess time would be the dose in this case. But basically, you look at kind of a cumulative percentage of subjects that exhibit that defined all-or-none effect over time. So again, if you are plotting, you're going to look at the log of the dose of the drug, and then that ED50, or this median effective dose, when we're talking about it in this case for these quantal relationships, this is basically when you have 50% of the people achieve whatever outcome you're looking at. Okay, so 50% of you guys are asleep, so I guess it would be, I don't know, 15 or so of you would be asleep. I mean, 14 and a half. I don't know what a half of a BA student looks like, but I don't want to find out. Anywho, so again, sleep is a very good example of kind of this all or none phenomenon. So if you're using something like inhaled anesthetics, I guess very similar to the guys down the hallway, right? Sleep would be defined as kind of your all effect. So you're either yes, no, or sleep, right? Awake would be this kind of none effect. So ED50 would be that dose of sedative that I would need to give to get 50% of those patients asleep. Okay, so again, we have our ED50, 50% of whatever desired effect we're looking for in a population that manifests that effect, whatever that dose has to be. We'll also look at toxic dose 50, and we can start to compare these. This is when you start to look at, as you define a side effect for a drug. So say we're looking at sleep as being our effect for a sedative, but what about the side effect of, say, respiratory depression? Right, so we can start to compare and contrast those to see, well, how close are those curves together? Is there overlap there? To where if I increase my dose high enough, I'm going to start to overlap on this other adverse reaction curve and start to see some toxicity there, right? Because generally you want to put your patients to sleep, but you don't necessarily want them to stop breathing, right? Unless you intubate them and then you're breathing for them. We'll also look at the LD50, which hopefully you guys should not be shooting for getting to these doses anytime soon. But this would be where you would basically be killing off 50% of the subjects in the study. Okay, most of the time this is coming from animal data to try to determine what LD50 is, or if you have like kind of retrospective data looking at patients who have died from a given drug, you know, say, okay, what was the kind of the median dose that it took to kill these patients? Okay. All right, so you can look to see this comparison between here you would have your therapeutic effect being illustrated by this ED50. You can have your toxic effect here, and notice how it can vary how close these curves are together, right? So this could be, if we're talking about sleep here, there could be respiratory depression, and then here could be death we're looking at as our kind of our LD50, right? Again, typically you're going to want these curves to be far as apart from each other as possible, because I would like to be able to give a very big dose of a drug and see no side effects. That would be preferable. In a lot of cases, you're not going to run into that. Okay, it can be very hard to get to that point. So we can look at this relationship between these different curves, look at the therapeutic effect, look at the toxic effect. So you can either look at, if you're making certain comparisons, you can either use TD50 or LD50, depending on kind of the comparison you want to make here. But this allows us, when you use either one of these, to calculate a therapeutic index. Okay, this is basically going to be the ratio of the LD50 or the TD50 and the ED50. Okay, that means, so here, if you're thinking about this, think about this relationship between one and the other, would you like to have a very high ratio or a very low ratio? Think low? If it's low, that means that these curves are very close together, because this ratio of this point to this point would be very close together, right? So if you're close, the closer you are to 1, the closer they are to just being overlapped completely. You want a very large therapeutic index. You would like this curve to be as far to the right as possible, so that even if I give a ton of the drug, you're never going to see someone die from that, or someone manifest toxicity. And that would be preferable. But when you're looking at therapeutic index, now you can start to compare different drugs together to see, like, okay, well, this one may be more potent, this one may be a little bit more efficacious, but it's also more likely to see side effects. The therapeutic index is lower for this drug. Maybe I don't want to use that. Maybe I want to go to this other drug that's going to be safer and have a larger therapeutic index. Okay. So again, just looking for this margin of safety here where you can start to increase your dose. And notice here, once I get to a certain point, now I'm going to start to have overlap here, and you're going to start to see that toxicity start to manifest, right? So we'd like to give a dose and get 100% efficacy out of our patients, but that may be getting to a point where they're going to start to see side effects. And that's maybe no good for your patients, right? Again, therapeutic index is that TD50 or LD50 divided by your ED50. You want a larger ratio. You'd like a larger number if possible, so that would indicate that this toxic side effect or death is going to be as far to the right as you can. Okay, and so we'll talk about some comparisons of those in just a second. So again, the ratio between the dose causing undesirable effects, either lethal or toxic, and the dose causing the desired therapeutic effects, or our therapeutic indexes. And we're going to talk about drugs that have narrow therapeutic indexes and drugs that have large therapeutic indexes. So again, high TI is going to be preferable to a low one. And so an example of this would be the case of something like diazepam, which diazepam is a drug, otherwise known as Valium. You guys ever heard of Valium before? What type of drug is that? It's anti-anxiety, it can be anti-seizure medication. Yeah, so those are kind of the two main things we'll sometimes use for sleep. This one is relatively forgiving. This means that between the ED50 and the TD50, or in this case probably LD50, I'd have a ratio of 100, which means I would basically, if I'm at the ED50 dose, I'd have to give 100 times that drug in order to get to the LD50, right? That's pretty safe. I mean, it's very hard to get to a 100-fold overdose in a lot of cases, right? Unless you're really trying hard. Versus something like digoxin. You guys ever heard of that drug? It's a heart medication they'll sometimes use for congestive heart failure or for patients with atrial fibrillation. This is very, very narrow, meaning that even if I were to have a slight change in dose, I'm more likely to run into toxic effects, into potentially deadly effects. And so again, larger numbers can be better. Smaller numbers can mean they're not as forgiving, which means you're more likely to run into problems at even small changes in dose. Okay. Okay, so this goes back to this term narrow therapeutic index, and you'll hear me refer to drugs like digoxin, you'll hear me refer to drugs like vancomycin, which is a really kind of potent antibiotic for like MRSA or that methicillin-resistant Staph aureus. You'll hear me refer to several drugs like that. That typically just means that you're going to have a smaller ratio, a narrow therapeutic index, which means you're more likely to see toxic effects, even if you're still achieving some of those, even if you have not achieved full efficacy for that patient, right? There's just going to be some patients, when you're trying to dose them to get them to be at an efficacious point, they're going to start to overlap and start to have some of those toxicities, okay? That could be anything from just, it could be cough, it could be diarrhea, it could be full-blown renal failure, it could be lots of different things. It's whatever you define it to be in these cases. So generally, a drug with a narrow therapeutic range may have its dose adjusted according to measurements and actually by measuring the level of drug in the plasma. So when we talk about therapeutic drug monitoring in a couple of weeks, we're going to come back to this to see, like, well, I can draw levels of the drug out of the blood, see what it is, and be able to dose the patient to make sure they stay in the therapeutic range without going too high or too low. Okay, so we'll do that more often with those narrow therapeutic index drugs. I'll give you some examples later on. Okay, so just some examples of drugs we might do therapeutic drug monitoring and that have narrow therapeutic indexes. We have drugs like theophylline. which is a drug we kind of really old school drug we use for asthma. If this gets too high levels, you can see things like arrhythmias, you can have seizures occur. We would target certain levels to make sure the patient has their asthma controlled or their COPD controlled, but they don't get to those high levels that could lead to those kind of either cardiovascular or neurologic effects, right? So we have a whole list of drugs that we'll do this for. We'll talk about these more in detail as we get to specific classes in pharmacology, but just to kind of give you, show you some examples of ones we might actually look at. Yeah. All right, so we mentioned narrow therapeutic index drugs, small dose range between what's effective and what could be toxic or lethal. If you have large therapeutic index drugs, it means they're much larger, larger dose range you can cover. So, for instance, that drug Valium or diazepam that falls into the class of drugs called benzodiazepines. Right, that one has a very wide therapeutic index for the most part. And so, one thing how it was explained to me was that the only way you would ever die from an overdose of something like Valium, if you're taking orally, was if you get hit by the truck that was delivering it. Right, so you can see drugs have a very wide therapeutic index where you can take a ton of it and not really, you may have some toxicity, but you probably wouldn't die from it, right? Versus some drugs are very dangerous, where even a small amount over what the patient normally would get could lead to pretty serious toxicity. Okay, digoxin is a very good example of that, where especially if they're not able to clear it well because their renal function went down, or if their liver function took a hit, and you don't adjust the dose, they can run into problems. Okay, so a summary of the curves. Both Quantal and dose response curves, they're going to be graphed as either linear or semi-logarithmic. Most often we're going to use logarithmic or semi-logarithmic, so that way we can look at a wide range of doses that we can administer, and they're going to be providing that critical information so we can make a rational choice about what kind of drug would be better for a particular patient. Okay, a lot of this is done on the background side and the drug manufacturing side, so that way when you get to your references, a lot of it's already been kind of dealt with. But now you can understand why one drug might be dosed a certain way, and might be a bad choice for your patient versus another one is dosed a different way. It might be a better choice depending on the toxicity. Yeah. All right, so let's look at why people there's variability in the doses or the response people have to different doses of a drug. For instance, I have a cousin who every time he takes a drug, no matter what it is, he has the weirdest side effects I've ever experienced. I cannot explain it as a pharmacist. He's just a weird guy. He might also be a hypochondriac, so that could play a role there, but basically, people are going to have variations in response. Some people respond very well to one drug. Some people get terribly sick off of it, right? A popular one I always hear about is like hydrocodone, right? Hydrocodone's found in things like Lortab or Norco. Some people, they love that drug. In fact, they love it too much, and they get hooked on it, right? Some people, it's terrible for them. They get so much nausea, vomiting associated with it, they just feel awful. They never ever want to take it, right? So they get to a point where they have surgery, they don't even want to take meds for it, right? So people can have a lot of variability in response. We'll kind of look at why that is in some cases. Basically, even if you're giving a patient the same drug at different times during treatment, they may have different responses to it based on how the disease process is going, based on several different factors. And so you really need to kind of consider all points when prescribing a drug and trying to predict how a patient may respond to that dose. So we'll look at some of the different types of responses we can see here. There's idiosyncratic responses, which we're going to say, like, we don't really know why they happen. We'll talk about tolerance and tachyphylaxis. And we'll talk about hyper and hypo-reactive responses. So again, idiosyncratic responses, these are pretty rare, kind of abnormal responses to the drug, and they are not going to be really predicted by the mechanism of action of the drug. If you need me to pause so the helicopter can go, are you guys hear me okay? No? I'll pause for a second. Okay, so anyway, so again, rare abnormal responses to the drug. Based on the mechanism of action of the drug, we can't really explain why the manifestation is happening, right? It's definitely not an allergic response, even though some people will still call it an allergy, and that's kind of one of my gripes from the hospital standpoint. Is people say, "Oh man, I have an allergy to penicillin." Okay, well, what was your reaction? I had some diarrhea. Okay, that's not really an allergy. Don't give it to me though. Okay, well now I can't give you any penicillins, I can't give you any cephalosporins, and a whole list of drugs I cannot give you anymore because you don't really have an allergy. Okay, so it's one of the things you run into, and you gotta be really careful when you say something is truly an allergy. But basically, it also cannot be produced with regularity, right? So if you give the same dose of that drug to a different patient, they may not have that same idiosyncratic response, right? All of it can depend on things like pharmacogenetic differences, so based on the genes that they are expressing, or based on things like the metabolizing enzymes they may be expressing. All that can change between patient to patient, so they may not have that same response. So that would be considered an idiosyncratic response. So some of it may or may not be dose dependent. Sometimes patient can tolerate one dose and then you start to go up above that and they'll start to manifest this kind of effect. And again, potentially an uncommon response to a drug due to that genetic predisposition. So a really good example of this would be kind of an old school drug called Primaquine that was used for malaria. And basically you can have some patients who respond very well to this and they can have their malaria treated, no problem. Some patients would actually be deficient in an enzyme called glucose-6-phosphate dehydrogenase. And so you guys will hear this come up later on in different courses, but you can have patients who are G6PD deficient. Okay, so if you ever hear that again, this is what this is referring to. And essentially they can express a normal amount, right? So most of you guys probably are expressing a normal amount of G6PD. They can express differing amounts to almost no G6PD. And so those patients, when they get a drug Primaquine, if they don't have enough G6PD, they can actually end up causing hemolysis, which is, what's hemolysis? Breaking down the red blood cells, right? So basically lysing open all those red blood cells, spills out all that content. It's not good for the patient, right? Because we like to have red blood cells around, typically. So anyway, those type of patients, and it can be very hard to predict if they've never had a reaction to that before. And it can be something that we screen for occasionally. Sometimes it's things that we don't screen for routinely. Because again, if I were to test every single patient that came to the hospital to see what their G6PD status was, it would be very, very expensive, and I would probably get very few hits off of that. Okay, so again, a lot of times you're not going to be testing for these things routinely. You just have to be able to say, like, okay, you had this reaction. This probably means that you are this type of metabolizer, or you have this type of enzyme deficiency, or whatever happens to be. So people can be hypo or hyper-reactive to a given drug. So again, the intensity of the effect of the dose that I'm giving could either be diminished or very much increased compared to what I would typically expect to see. So a good example is diphenhydramine or Benadryl. Do you guys, anyone know how that drug works? What class it falls into? Antihistamine, yeah. So it's actually blocking H1 receptors and antihistamine. If you ever take a dose of Benadryl, how do you normally feel afterwards? Very drowsy, right? So that could be something we would expect to see at a given adult kind of therapeutic dose. For some people, they can take small doses and get super sleepy off of it. Sometimes in kids, if you give them a standard dose based on their weight, they can have this kind of paradoxical reaction where they get super wired. Like you'd expect them to go to sleep and they are just wide awake and they are bouncing off the walls and they're throwing stuff and chewing on things and they get crazy, right? Cannot predict really why that is based on the mechanism of the drug, based on these different things, but it's something we can at least predict, right? So sometimes it can have the opposite effects of what you would expect to see there. Another good example would be opioid pain medication. So did I mention codeine reaction last time? Right, so some of these patients who may have been deficient in CYP2D6 may not be metabolizing codeine very well, so they don't get a ton of morphine out of it. They don't get a lot of morphine, they don't get a lot of good pain control. On the flip side of that, you have those patients who are expressing too much CYP2D6, and they are going to be metabolizing a ton of that codeine over to morphine. They'll get good pain relief, but they can also have respiratory depression, right? So there's some deaths associated with that for people who are overexpressing that CYP2D6 in those cases, right? Again, do we check every single person who walks in the hospital or into the clinic for CYP2D6 polymorphisms? No, we probably should, and we probably will be at a point, say 50 years from now where that sort of testing is very easy and cheap, but as of right now, we can't really do that. So in a lot of cases, you may do things like take a drug off formulary. So like at Nemours, we do not carry codeine anymore because of this risk for some of these patients who may have these polymorphisms, right? So tolerance is something that happens with several drugs, especially those that are going to be kind of active within the central nervous system. So if you had to describe tolerance, how would you guys describe it to a patient? Good. That's perfect, right? You need a higher dose in order to achieve the same effect, and this is an over time kind of thing, right? So certain drugs, you're going to develop tolerance to it based on the fact that you can have things like you can change how the receptors are being expressed. So if I have an activator, if I have an agonist around chronically, sometimes you can see downregulation of those receptors, right? So the body's trying to maintain homeostasis as best it can, and so this is where some of these tolerance type of effects come from. This is a big thing that happens with opioids. Again, that's why you don't want to cut people off cold turkey from opioids because they go into withdrawal, which we'll talk about a little bit later. Benzodiazepines, which I mentioned, like Valium being one of those, but they're used for sleep. They can be used for seizures. People can have very violent reactions when they're withdrawing off of that. And then stimulants as well. So is anyone abusing caffeine even right now? Probably most of you guys. What happens if you withdraw from caffeine? Massive headaches, right? All the blood vessels are just going wide open and they're just causing all this cerebral blood flow and it hurts, right? So again, you develop intolerance. And also, if you're looking at the dose of coffee you had to drink to get kind of a nice burst of energy at the beginning of PA school versus the amount you need to get at the end of PA school, how do you think that would compare? Yeah, it's one of those really steep dose response curves where you're going to need a ton of coffee just to get any kind of response. Yeah, it's straight up, right? Like, yeah, I can drink a ton of caffeine, and like it just keeps me regular at this point, right? That's how much tolerance I have to it at any given point. So same things are happening with these drugs, and this could explain why a patient comes back and say, hey, I'm not getting that same pain relief I used to. You may think, well, they're probably trying to get more pain meds out of me. I'm not going to give them anything else. But it could be legitimate. They could say, hey, I'm just not really getting that same pain control. A lot of it has to do with this tolerance effect that happens there, right? Yes?
Is it something that sticks in the system where you've been on, say, an opioid and you've built up a tolerance and increased your dose and now whatever was going on is not going on. You don't need to take that dose anymore or that medication. A year later, something else happens where you need to get on. Are you sort of starting where you left off before, or can you go back to like the lower dose?
Yeah, so it's a very good question. So yes, you can go back to baseline, right? So a lot of these changes as they happen over time, so you give an opioid, you're hitting these opioid receptors chronically, say for a year, right? You fix the patient's back pain, now all of a sudden they don't need it anymore, they come off of it. Those receptors will go back to kind of their original configuration, they'll get back down to a baseline level so that when they go back on it later on, they need to start at a lower dose, right? So that's kind of one of the problems they would run into where patients with who are trying to get off of opioid addiction, right? There's a problem where they would say they do heroin and they knew exactly how much heroin they need to do in order to get their high, right? And again, usually it's a lot higher dose than what they needed when they first started trying heroin, okay? They would try to go into opioid treatment. They would try to switch over to some other medications to try to wean them off of those opioids. And now all of a sudden they're saying, like, nope, I'm out of here. I'm done with treatment. They go back and they get their original dose of heroin, right? Now all of a sudden they've had some time to re-equilibrate. They're getting back down to close to baseline. Now they're dead because they thought, hey, that's still a good dose for me, and didn't realize it's way too much for them. Okay, so absolutely that adaptation occurs in both directions.
Is there a norm for how long it takes the receptors to go back?
All depends on the patient, depends on how long the drug sticks around for. Things with very long half-lives can be in the system for weeks or months. It just depends on the person too.
So after they get down to baseline, can they hit tolerance faster?
I don't know if the time to tolerance changes necessarily. It could be some of it has to just do with like the frequency of dosing. Sometimes it has to do with how long the drug sticks around in the system for. I'm not sure though that the time actually changes much. Or I don't know if that research has been done at least to answer that question. Good question though. So there's another term called tachyphylaxis, so it's kind of similar to tolerance, but essentially this is a case where a patient will start to lose effectiveness of a drug, and no matter how much extra drug you give on top of it, you see no additional response. Okay, so a good example of this we'll mention is going to be a nitroglycerin for chest pain. When you look at the dosing for nitroglycerin, did anyone have nitroglycerin for their drug? Probably didn't say that one, but if you were to look at the dosing, you'll notice, especially for things like long-acting forms, like they have creams you can put on, they'll say be on for 12 hours, then take it off for 12 hours, then put it on for 12 hours, and take it off for 12 hours. This has to do with that tachyphylaxis. Essentially what you can do is you can lose response to a drug over time because you exhaust certain biochemical pathways, you run out of an enzyme, cofactors, whatever happens to be. But no matter how much extra nitroglycerin I give that patient, once they've lost that effect, it's not going to happen again until I've given them a rest period, allow them to kind of get back down to baseline, and then now they can have effect again. Okay, that's why those rest periods are built into certain drugs, nitroglycerin probably being the most common one. You see this as well with certain stimulants, especially things that force the neurotransmitters in the brain to send out more norepi and dopamine and things like that. You can wear out those neurons to where they want to send out more of these catecholamines, but they just can't. They run out, right? So people that go on really long benders, like over say like a July 4th weekend, they go on amphetamines that whole time. By the end of it, their neurons are just fried and they can't send out anything else because they need time to recuperate to build up more catecholamine stores. Okay, same thing can happen there. But so you ever see that on 12, off 12 kind of time frame, like that's usually what they're doing it for, is to allow for that tachyphylaxis to abate and get back down to the baseline. All right. So some of the mechanism for how we get this dose response. So kind of 4 general mechanisms that can occur here that can kind of vary the response you'll see with a drug. So one, you can have alteration of the drug concentration that reaches the receptor. We'll talk about some details on that in a minute. We'll talk about variation in the endogenous ligand concentration. We're going to look at the alteration in the number and function of receptors that are there. And then we'll look at some of the changes in components for some of those downstream responses to the receptor. Okay. Looking at the alteration of the drug, how much drug actually gets down to the receptor. Some things we can see is that you can actually have pharmacokinetic changes that occur. So either things like absorption have changed, distribution, metabolism or excretion of the drug has all changed. So a really good example of this would be upregulation of certain hepatic enzymes to break down a drug called carbamazepine. Carbamazepine is a drug used for seizures originally, but nowadays you see it used a lot for bipolar disorder as a kind of a mood stabilizer, essentially. And so what you end up looking at, if you looked at the dosing of carbamazepine, see you start at this dose, and then a week later you go to this dose, and a week later you go to this dose, and it keeps kind of ramping up. The reason for that is because when you start to challenge the body with that drug, it starts to ramp up metabolism of it. The liver once it says, hey, I want to get rid of this, I'm going to start to produce more enzymes. And so if you left the patient at that starting dose, they'd be metabolizing so much of it, they really wouldn't get any effect out of it. So that's why you can gently ramp up the dose to get to a point where you kind of reach a steady state to where the patient is going to be getting good clinical effect and the liver's not really upregulating any more enzymes, right? There's always a limit to things when it tries to have these kind of compensatory effects, right? So that'd be one good example. Other things can change as well, so things like age, gender, weight, disease states, genetic differences in how you can actually metabolize the enzymes can all affect how much drug is actually getting into the system and over to the receptor. So good example, looking at changes in the actual active transport, you can have active transport proteins that are responsible for doing things like sending drugs outside of the body. So we have one called an MDR, or a multi-drug resistance gene. This is really involved in trying to send drug outside of the body back into the GI tract. This is a substance is also found on the blood-brain barrier and sends molecules that cross the blood-brain barrier back out to the bloodstream, right? Because normally you want to keep stuff out of the brain for the most part. Some of these patients will actually have upregulation of this protein, so that way they are effluxing even more drug out of the system, and by doing that, it means for a given dose, less of it is actually reaching the receptors to actually work with the patient, right? We actually had one patient who, there's a drug called loperamide. You ever heard of that one? Brand name's called Imodium. It's antidiarrheal. It actually looks a lot like an opioid, but because of the fact that it cannot cross the blood-brain barrier, it does not act like an opioid. Don't get the kind of euphoria effects out of it. The reason for that is because these MDR transport proteins prevents it from getting up into the CNS. If anything does cross the blood-brain barrier, it would just kind of spit it back out into the bloodstream, right? So we had this one patient who decided, well, I'm going to use a substance. They probably looked it up online. They said, I'm going to do something that's going to inhibit that MDR gene, or inhibit that protein. So they took another drug called cimetidine. Also called Tagamet, so it's another over-the-counter med that you can find for gastroesophageal reflux disease, right, for GERD. So that drug inhibits that protein. Took a ton of that, and took a ton of loperamide, and all of a sudden a lot of this drug ended up going to the CNS, so she ended up having all kinds of bad effects from that, and being intubated, and going into all kinds of ventricular arrhythmias. It was bad news for her. But because she was able to look up the kinetics of these drugs and look up these interactions, she could affect the amount of drug actually getting to that receptor, okay? Did not go well for her, which is why I do not advocate you doing that. But it's interesting some of the things that people go to in order to get high. But also those MDR genes, that transport is really important for things like resistance to cancer drugs. So that way you can see that a drug would be really good for treating cancer for a while. But if it's not able to get to the site where it can actually work to do things like change DNA proliferation or things like that, the drug's not going to be effective anymore. So that can be one thing we run into with some of our hem-onc patients. So switching over to looking at the variation in the endogenous ligand concentration. So a good example of this would be a beta blocker called propranolol. It's a very common one. This is going to be a beta adrenergic receptor blocker. So it's blocking those beta 1 receptors and beta 2 receptors, but primarily kind of stopping that on the heart. And so what we see is that we can use this drug for stage fright, or we can use it for performance anxiety, right? So if I was getting like really nervous coming up here and talking in front of you guys, what would be some of those things I would manifest? What do you think? What would my heart rate be doing? It'd be tachycardia, it'd be beating on my chest, right? I'd be getting sweaty, it'd be kind of having some tremors, it'd be very, very nervous. What you can do is give propranolol to people, and that will actually have to block some of these effects, right? So I'd be getting up here, those beta receptors in the heart would be blocked, so that way I would not get that tachycardia. It would help with the tremors in the skeletal muscle, it would help with the sweating and all of that. But that drug would only really work when there's high amounts of catecholamines being sent out. So if I took it, if I was just walking down the street and I'm not nervous at all, I really shouldn't be getting any effect out of that drug. It would only really be working if I'm in a high stress, kind of that sympathetic kind of state, right? So based on the amount of endogenous ligand that's around, the drug may or may not be effective, right? So again, why we'd only recommend it for like, okay, only do it before a performance or whatever you get nervous at.
Does the drug help with any anxiety psychologically, or is it just a physical effect?
Not really, mostly just a physical effect. Yep. absolutely. But like we had some students, like when I was in pharmacy school, we had a class called pharmacotherapy, where basically you had an expert in a field down at the front of the auditorium. You get called on at random to say, okay, well, what drug would you use based on the guidelines, based on this study, what was the patient population, and you get called on at random, and you just stand up and be like, oh gosh. And some people use propranolol, right? I was kind of mad about that because I thought it was the kind of performance-enhancing drugs, but whatever. I graduated, still got my PharmD. But in that situation, you had a lot of catecholamines around. That drug would be effective then. But if I took it just at kind of baseline, really wouldn't be doing a whole lot. Okay. So looking at the alterations in the number or the function of receptors, sometimes you're going to see that the available receptors can increase or decrease based on the type of exposure you're having. This can be caused by hormones. So for instance, if you're looking at thyroid hormones, like hypothyroidism is a big thing you're going to deal with a lot of patients. If you have extra thyroid function, you're going to notice you're going to have an increased number of beta receptors in the heart, which means you're going to be more likely to respond to things like epinephrine, okay? Versus if you had low thyroid levels, you notice you have less beta receptors, so you may not have as much effect if you're blocking those receptors with that kind of drug, right? So, and again, when you have these effects occurring, this is where tachyphylaxis and tolerance can help to reduce those number of functioning receptors. So if I'm constantly activating with an agonist, a receptor, the body's reaction to that is going to be to reduce the number there. So it's going to downregulate those receptors in order to try to kind of maintain homeostasis, right? All right. So you can have desensitization that can occur over time. So if you have a kind of a repeated or a continuous administration of an agonist, or in some cases even an antagonist, you can see changes in responsiveness to that receptor over time. So you may not have a change in the actual number of receptors, but they may change some kind of conformation or something, so they're less sensitive to the effects of that drug. And this is usually kind of a protection mechanism for the cell to say, hey, I'm getting too much activation here, I'm getting too many of these effects, let's try to protect things and try to diminish the kind of maximal effect you can see there. So drugs can become less effective over time if you maintain that same dose. So again, when you have repeated drug administration, it's going to result in that diminished effect there. And then again, when you have that tachyphylaxis, no matter how much you increase that dose, you're never going to get more effect out of that drug. Versus tolerance, you can overcome tolerance by giving more of a drug. So there's kind of an important distinction between those two. When you have tachyphylaxis, the receptors are usually still there. They're just really not really responsive. Okay. Okay, you can kind of see this slide here, how responsiveness can change over time. So say, for instance, I were to give one dose of a drug here, you notice how it has this peak effect and it kind of wears off. If I were to give it very soon after that first dose, you can notice that the peak effect is going to be lower than it was for that first dose. That would be kind of a tolerance or kind of a tachyphylaxis kind of effect. Versus if I were to wait some period of time, say another hour or so, I can get back to full effect there. So again, that desensitization, sometimes it can happen over the course of hours, sometimes it's going to happen over the course of days to weeks to months, depending on the type of drug you're dealing with. Okay, and so if you have, if you're trying to give drugs or trying to do something during this recovery phase, we can consider the patient to be unresponsive or refractory to that dose, right, to that drug that we're giving at that point. Okay. You have to worry about rebound phenomenons for some patients based on what you are doing to the receptor number or function. So for instance, if I give a drug called propranolol, if I'm blocking beta receptors, again, which is slowing down the heart, do you think the receptors there, are they going to upregulate or downregulate in response to that antagonist? So you're blocking those beta receptors, like, hey, we're not really having a whole lot of epinephrine activation right now. What can I do to respond to that? Upregulate or downregulate receptors? Upregulate, right? So it's saying, well, we're not having enough epinephrine activation. Let's go ahead and upregulate. Let's send more receptors up to the surface so they can be activated by epinephrine, right? What happens is you rapidly withdraw that type of drug. Now all of a sudden you're left with a ton of beta receptors around. And now that epinephrine that your body was still releasing kind of normal amounts, it's going to hit all of those receptors. And then you get kind of an overshoot on the opposite effect. Okay, so you can end up seeing increased heart rate, increased myocardial oxygen demand leading to MI. So there's been cases where people will come off of some of these cardiovascular drugs and end up leading to MI secondary to that because the heart's working too hard when it gets hit all at the same time with that. Okay, you can see this a lot when you familiar with the drug Afrin. Right, it's a nasal spray. You use it for nasal stuffiness. When you take that drug, it actually squeezes down and vasoconstricts on all that nasal mucosa, so it actually decreases the amount of edema you have there. They tell you don't take it for more than 5 days, right? Because of the fact that if you take it for more than 5 days, your body gets used to having that vasoconstrictive effect around. If I stop using it, all of a sudden you're going to get just a ton of rebound effect. You get a ton of nasal stuff in his back, and have a ton of snot, and runny nose is not going to be good. And so people will end up getting kind of hooked on this stuff because they don't want to have that rebound effect. I knew one pharmacist who worked at a big long counter at Walgreens, and he had a bottle of Afrin, basically kind of 3 different points, so he could always just take a hit whenever he needed to if he felt that rebound effect coming on, right? So very, very not super common, but think about cardiovascular meds as being one of the main sources for this. There's a little picture kind of showing this effect here. If you imagine these to be beta receptors on the surface of the heart, probably should be red, but whatever. If you notice, this is kind of like natural kind of catecholamines like epinephrine. If I were to have, say, normal activation, that can have a heart rate of 75, say, like a blood pressure of 145/90. And if I were then to block that with something like propranolol, you see how the heart rate would drop, maybe blood pressure would drop as well, kind of down to normal ranges. And then in response to that, the body says, well, let's upregulate receptors, let's get more of these out into the cell surface and try to get some kind of more natural kind of epinephrine kind of activation there. And then if I were to, say, cut my beta blocker off cold turkey, now all of a sudden you're going to have way too much activation through these beta receptors. You're going to have heart rate through the roof, you're going to have blood pressure going through the roof, and that can potentially lead to an MI or something, some other kind of bad outcome. Okay, so you got to be careful of the rebound effect, and when they mention that you should taper off of a drug, there's usually a good reason for that happening. Okay, another thing they always tell you to taper off of is going to be steroids, right? If I give you corticosteroids like prednisone or dexamethasone, if you take it for a long period of time, you're going to find that things like your adrenal function is going to decrease. Because when the adrenal gland detects, hey, there's enough cortisol around here, I don't really need to produce any of my own, it starts to atrophy. And if I were to cut off that corticosteroid cold turkey, if I stop taking prednisone all of a sudden, now the adrenal gland needs time to start to produce again, and so you end up going into adrenal insufficiency, you have problems with blood pressure, all kinds of issues, and patients can go into the hospital for that. Okay, so again, watch for those tapers. There's usually a good reason for why they recommend doing that. Okay, so looking at genetic factors, we mentioned some of these already, but for example, changing the actual receptor function. There's not a good number of clinical examples of where this can play a role, but for example, if you're looking at something like deletion of these alpha-2C receptors, some patients have a deletion here where they may actually have increased response cardiovascularly to certain stressors. They may be more likely to get some of these effects from there. This is a mutation you see 10 times more prevalent in African Americans versus Caucasians. So again, this may be why you like to use one type of drug in, say, a Caucasian patient versus another type of drug in an African American patient. All can depend on certain genetic differences, kind of manifested on average by those populations. Okay. Some of them may or may not be proven clinically, but usually things like guidelines already take some of those things into account. Okay. You can also see some changes in the components kind of downstream or kind of distal to the actual receptor. So there can be other things that are happening than just at the receptor site. For example, this would be if you're administering, say, like a beta blocker to lower blood pressure. Okay, so I lower my blood pressure, given a beta blocker. Well, the body wants to maintain homeostasis and wants to get that pressure back up to where it's kind of used to having it. So it can do things like, okay, well, maybe the kidneys are going to start to hold on to more water, right? That can raise blood pressure, or we're going to start to release more of a hormone called renin, which can lead to blood pressure increases as well. And so again, in general, you're going to find that you're kind of fighting these homeostatic processes to try to change things. Because when a patient's hypertensive for a long period of time, they're just used to this is my baseline now, right? So if you try to monkey with that, then the body's going to try to compensate. Okay, so real quick, we'll go over clinical selectivity. So looking at beneficial versus toxic effects. So again, we'll see that drugs generally are going to be relatively specific to certain receptors. You're going to find that some of them are only going to affect one type of receptor. Sometimes they're going to have some play there, and they can actually affect multiple types of receptors. So even though they are intended to be attracted to certain types, they can affect other types of receptors as well, which may lead to toxicity, may lead to therapeutic effect. It just depends on the drug. The big thing to remember is that if you have a drug that says, hey, we're selective only for the beta-1 receptor, all dependent on dose. If you drive a dose high enough on a drug, you lose selectivity, and you're going to have activation of other receptors as well. Okay, so that happens when we're dealing with beta blockers, especially if you say, hey, this is a beta-1 selective beta blocker. If I drive the dose up high enough, I'm going to lose that beta-1 selectivity and then start to hit beta-2 receptors as well. It's all going to be dose dependent in those cases. So in general, though, we like higher selectivity. We like things to be very specific and only affect one type of receptor. So that usually is going to limit the type of side effects we're going to see there. So a good example of this nowadays is the fact that the pesticides that we use usually in America are going to be mostly these pyrethrins, right? So if you were to go to buy an insecticide from the hardware store, you would notice that most of them are going to be this pyrethrin base. We used to use drugs called organophosphates. Okay, organophosphates are still used occasionally for people sometimes, but they use this a lot over in like certain developing countries where this is a much cheaper, very effective way to deal with insects like in crops and whatnot. Organophosphates are not very selective for the insects you're trying to kill. They can affect people just as much as they do the insects, which means that it's very, very toxic to humans. Versus the pyrethrins we use nowadays here in the U.S. are more expensive, but because we are able to afford that kind of safety margin, we can use drugs that are very selective for bugs, kill the insects we want to kill, and not really be as toxic to humans. So if I have a patient that called up the poison center and said, hey, I accidentally drank this pyrethrin, or my kid drank it, I'm not going to be nearly as concerned as they call up and say, hey, they drink this organophosphate. And we're like, oh crap, they're in bad news, right? So we like selectivity. We like things to be selective as possible. We run into problems with this with thinking about like cancer drugs, right? So if I give you a drug to treat cancer, it treats the cancerous cells for sure, but it also affects your healthy cells as well. It's very difficult for these drugs to be able to tell the difference. And that's why you see so many side effects associated with chemotherapy, because it does not have a ton of selectivity. On the other hand, you have things like antibiotics, which do have pretty good selectivity. They're able to kill the bacteria, but not really kill us, right? Sometimes you'll lose a little bit of that, but for the most part, it likes to be selective against specific targets. And that's always a good thing. So we can look at selectivity. We can measure that by comparing things like ED50s together to look at the different effects of a drug to see which one is more potent at causing a specific effect, the one that we're kind of interested in. And basically in drug development, selectivity is always going to be considered there. And you kind of can split those effects up between therapeutic effects and the toxic or the side effects we'll deal with. So you can see that sometimes beneficial effects and toxic effects will be mediated through the same receptor. So again, if I give you a beta blocker to lower your heart rate, and then all of a sudden you get bradycardic, that makes sense because that's through the same mechanism, right? So the therapeutic effect and the side effects through the same process there. Another good example would be warfarin. You guys ever heard of warfarin or Coumadin? It's a blood thinner, try to prevent clots from forming. So the intended effect is to thin the blood, right? Obviously you can go too far on that and get the blood too thin, then have a bleed, and that's bad, okay? So again, all through the same effect though, all through the same mechanism of how it thins the blood to prevent stroke, it also can cause massive head bleed. Okay? Insulin is another good example where we give insulin to lower blood sugar, give too much insulin, or they don't eat, hypoglycemia, right? So all through the same effect. And again, you have to kind of weigh the risk versus the benefit and say, well, what's the risk of them developing, a hemorrhage compared to the risk of them getting a stroke, or what's the risk of them hypoglycemic versus becoming hypoglycemic versus hyperglycemia, right? So you're always kind of running a risk-benefit kind of analysis there. And then sometimes you can find that the beneficial and toxic effects are mediated by the same receptors, but you're going to find that different receptors in different tissues will have different activities, right? So a beta receptor in the eye is going to be a little different than the beta receptor in the heart versus in the vasculature. So you're going to find there's some differences there. Good example of this would be things like glucocorticoids. These would be things like your prednisone and dexamethasone that we would use to treat asthma or COPD, okay? The problem with an asthma attack is you're having too much bronchoconstriction in the lungs, right? So all that smooth muscle in the bronchioles are going to be constricting down and not getting good airflow. So if I give you a steroid via the mouth, it goes to the whole entire body. So sure, it treats your lungs, but it also affects your glucose, causing hyperglycemia. It can affect your CNS. It can cause altered mental status in some patients, cause weight gain and water retention. So again, same mechanism, but in different tissues, right? The intended effect is really in the lungs, but I can't select for that if I'm giving a drug orally because it's hitting the whole body. So ways that I can combat that would be to say, well, I only want to give the drug right to the site where I want it. So I can give inhalers that will just get the drug right to the lungs, and then I spare myself all those other effects. So if you see Advair, or if you see drugs like Flovent and things like that, those are steroids, but they only are going to get delivered to the lungs. You lose a lot of the other side effects from that, which can be useful. Okay. And then you can have beneficial and toxic effects that mediated by different types of receptors. So this is where you kind of lose some of that selectivity in drugs that are affecting multiple things. So for instance, we can see that drug discovery oftentimes is resulting from ligands that bind to several different types of receptors. So a good example is epi, binds to alpha, beta, and some other receptors primarily. So we know that based on that selectivity, we can see that, okay, and we use this pretty frequently, especially like in ICUs and things like that. When I have a hypotensive patient, I can try to say, okay, well, if they're bradycardic and they're hypotensive, I know I can give epi because I know it's going to be affecting alpha receptors and beta receptors, right? So I know it's going to help to raise blood pressure and heart rate. Also, that can lead to the side effects as well I can see from either too much increase in blood pressure or too high of a heart rate, things like that. So it can be mediated through different types of receptors based on the mechanism. But in some cases, you'll find that we will try to make classes of drugs that target a much more specific subtype of those receptors or a specific enzyme. So for instance, the COX-2 inhibitors, when we talk about NSAIDs, things like ibuprofen, they affect two different enzymes, COX-1, cyclooxygenase 1, and cyclooxygenase 2. There are certain side effects that end up coming about from inhibiting the cyclooxygenase 1, things like stomach ulcers. But if I can give a drug that only inhibits COX-2, then I can end up saving the stomach, but still treating the patient's pain issues. Okay? There's some other problems with that which we'll talk about, but again, that was one attempt to try to make the drug more selective and lose some of those side effects. Also looking at things like histamine blockers. Certainly we have H2 blockers, which we use for things like GERD, things like that, Zantac or that Tagamet I mentioned. We have H1 blockers like diphenhydramine or Benadryl. Then we work on two different receptors, so we're getting much different therapeutic effects there. And then sometimes side effects of medications lead to development of other things. So minoxidil or Rogaine, what do you use Rogaine for? Hair growth. That's not originally what we were using it for. We tried studying it originally as an antihypertensive because it causes vasodilation. Unfortunately, it causes way too much vasodilation. Patients tend to have hypotensive episodes, but they also noticed the patients that were getting it, they were getting hair growth, right? Abnormal hair growth. They're like, well, that's kind of odd. Let's just rub it on the head and see what happens. Sure enough, hair grows. So we actually had a patient one time who he's a chronic alcoholic and ran out of money and could not get any of his own alcohol. So he decided to go into Walgreens and he saw the Rogaine bottle had like 15% by volume alcohol or something. Alcohol is a somewhat common solvent used to try to get drugs into solution, so it's not uncommon to see that. So he said, well, there's alcohol here, I'm just going to drink all this. So drank a ton of Rogaine, got so hypotensive, like, pressure's probably like in the 40s over 30s or something, and we probably gave him every single vasopressor known to man. He's on an epi drip, he's on phenylephrine drip, he's on norepi drip, dopamine drip, just everything, just try to get his pressure up something, to anything. And so fortunately, he survived, did not notice any abnormal hair growth, but just note that sometimes drugs can have kind of unintended side effects, and sometimes that's, we originally tried them for other things, found out they work for something else. You guys familiar with the drug Latisse? Ladies might know about it. What is Latisse used for? It grows your eyelashes. So it's actually a prostaglandin-based drug. They found that grows your eyelashes, but it was originally used for glaucoma. Right? Glaucoma is increased intraocular pressure. And so they saw that, okay, well, all these people getting treated for glaucoma, man, their eyelashes are looking great. So they said, okay, well, let's go ahead and market it for this. And so that's where you got Latisse from, right? It's a brand new brand name on it. They get another new patent on that. They can make money on that for a good long time. Okay. So again, when you're selecting an agent for a particular patient, you have to consider other factors like the side effects. You have to look at potential toxicities that can occur from this, the duration of effect of the drug. And so you're going to find all your patients are a little different. They may say this one drug is really good for them, this other drug is no good, right? And total opposite could happen in the next patient that comes along. So potency, efficacy, they're great to know, but they're not going to be the deciding factor in a lot of cases. You're looking at price, you're looking at the side effects, you're looking at all sorts of different things to try to see what is the best drug for your patient. Okay. All right, I'm glad I got through that. Any questions I can answer for you?
The diagrams maybe that you have the lecture that you say are a little bit more in depth than what we need. What do you expect us to be able to?
Know that if I have activation of adenylyl cyclase, what happens downstream from that, right? If I have activation of guanylate cyclase, what happens after that, right? I'm not going to expect you to know the full biochemical process for epi causing release of glucose from glycogen in the liver, but at least know that, hey, that's an adenylyl cyclase reaction there that's causing ATP to go to cyclic AMP, and then it can have protein kinases be activated. Those are the kind of things you should know. Okay. And so, yes, ma'am?
So it's kind of the end result is what you're looking for.
Essentially, yeah. Or at least the process is happening there, right? So again, you're having just know the steps of that process, but you don't have to know all the specific examples. I'm not going to ask you what arginine vasopressin is going to do within the kidneys. Like that's kind of outside of the scope of this class right now. Okay. The first test is next week, I think. I'm hoping they're going to give it to you before class. I'm hoping, because otherwise it's hard for me to get through all the material. So we're trying to do for farm. I'll have to message them. But it's, know the definitions, know the main concepts we kind of talked about in class. I'm not going to put like clinical scenarios that you guys are not going to really like have perspective for at this point, right? I know you guys are not practicing PAs, so I'm not going to make you guys diagnose an appy and then say which antibiotic should you use for this patient. That's not the point. The concepts are the big things to know right now. I will, if I mention a drug, I will at least give you the context to be able to make the mental steps and logic to get to the answer. Okay. I've never had anyone fail pharmacodynamics or intro to pharm like this before. I don't expect you guys to start. Okay. So don't freak out too much. Yeah, it's all multiple choice. Yeah. So I'm going to work out the logistics with them after this, and we'll see. I'm hoping it'll be on the computer. Yeah, that's what I send over to them as a digital copy. So, any other questions? 25. Yeah, so it'll be 25 just on the first 2 lectures. The next one is 25 over the second 2 lectures, and then the last one's cumulative, covering the whole thing. That'll be 50 for the last one. Okay. I'll look at the homework. I'll give any feedback if I need to. Anything else?
So when we take the cumulative, will we have access to the old test to see where we went wrong?
I don't know how they do that for you guys. I'm not sure. Look, I think you see, yeah, 2 exam thoughts, so you get to see it right after you take it. Anyone who, I'm actually not sure what their policy is.
You see it once, I think.
You see it once, yeah. I'm not sure if they, because we have a thing over at Nova where if like the student fails, I can go over questions you missed on the exam, but only if you failed it. So I'm not sure what the policy is here. You may want to check with them to see.
So it's going to be based on their policy.
Yes, I'm only going to do what their policy is because I don't want to get in trouble. I would like to still work here next year.
Where the department policy is how you look back.